Welcome everybody. This is Dr. Aida Wen. I'm geriatrician with the Department of Geriatric Medicine at JABSOM. Thank you for joining us again with our ECHO, our Long-Term Services and Supports COVID Preparation Series. We want to give a special thanks to our collaborators, the Hawaii Emergency Management Agency, Healthcare Association of Hawaii, Hawaii Association of Directors of Nursing, Hawaii Medical Directors Association, and Mountain Pacific Quality Health. At this time, please enter your name in the chat box for attendance purposes. And for those of you calling in on the phone, please take a moment to type your name if you can, or unmute yourself and tell us your name and we could write it down. We will be offering CMEs, and nurses can use these for CE purposes as well. We can also offer certificates of attendance for those who complete an evaluation. If you haven't registered yet, we encourage you to do so right after this webinar. Evaluations can be found on our website under the Evaluations tab or by following the link that will be posted in the chat box. So that's the slide for the CMEs. Next slide, please. And I just wanted to let you know, continue to check out all the other resources on our website. Just wanted to point out that we do have a new PPE resource document that was just updated last week, August 18th. And there's a couple of things to know, that if your facility gets any COVID, you can take a quick look at what to expect if there's a case, and that will help walk you through right away before DOH can help you out there. Next slide. And also want to let you know that there are additional resources for the community at Mountain Pacific Quality Health. They have a link for other tools as well. Next slide. Oh, that's it. Okay, actually, if you go previous slides. Anyway, I just wanted to let you know the calendar, if you don't mind. Yeah, so today our talk is going to be hospice care in the time of COVID. And then September 2nd, we're going to do updates in PPE testing and contact tracing, because, you know, it's a moving target and lots of things keep getting updated with new sources of testing and types of testing and prevalence testing, all kinds of things. And then on September 16th, we're going to talk about how to accurately report COVID deaths, because unfortunately we are having more of those as well. Okay, so we're really happy to have our guests from New York. It's we appreciate it. It's like 9 o'clock over there, 8 p.m. over there, and we have a whole team. And we have Dr. Rachel Dignam. She's in geriatric medicine and palliative care physician with the Visiting Nurse Services of New York Hospice Care, and she brought her whole team here, and I'm going to let her introduce everybody.
Hi, Aida. Hi, everybody. It's Rachel Dignam, and I brought our leadership from hospice as well as from our organization. I'll start with Linda Megan. She's our Vice President, Linda Wave. Yeah, she's our Vice President for the Community Access, and we have Donna Nellis. She is our Vice President of Operations, and we have Noreen Coyne. She's our Director for our Education Department in the BNSNY Hospice, and we have Mary Ann Kennedy, and she is our Vice President for in the Business Development for the organization. And we have Dr. Eric Elyayev. He will be joining me later in our presentation, and Adina Kalach. She is on the call, as she is our BNSNY consultant. And I see others, Wei Pan is also on, and she is our hospice nurse practitioner. I think that's all I could see right now.
Oh, we have Maria Lee too.
Oh, hi, Maria. Oh, yes, from New York. Hi, Maria. Yes.
Hi, how are you?
Maria is one of our community physicians that we work close as well. Thank you so much for joining us tonight. So, Aida, it's okay if I could share my screen?
Yes, yes.
Wonderful. Great.
Dr. Dignam, could you turn on your video? Your video is off.
My video. Oh, actually, I'm not using my camera, Adina, because it's been unstable here.
Oh, okay.
Yeah, okay. I'm just sharing my video. I said hello early on. Everybody can see my slides?
Yes.
My slide presentation, wonderful. Let me just get situated here. Good evening, everyone. Thank you very much for this opportunity to present to your group today. I am Rochelle Dignam. I am the Chief Medical Officer of the BNS-NY Provider Services and also the Hospice Medical Director. Today, I was invited on behalf of our BNS-NY team to share with you our hospice response to the COVID-19 pandemic and some of the lessons learned and continue to learn to date. I have no financial interests to disclose. The agenda for today, let me see if I can move my screen. No, I'm not able to move my screen. Hold on. Oh, there you go. The agenda for today includes a brief introduction of who we are as an organization, have a snapshot of COVID-19 situation in Hawaii, which I understand is rapidly changing. I would like to share with you the challenges that we faced early on at the beginning of COVID-19 crisis in New York and how we responded and continued to respond today. Later, I will be joined by Dr. Ilyayev as our guest speaker to share with you how we continue to collaborate with him as one of our community physicians in caring for hospice eligible New Yorkers at the height of this pandemic. Lastly, I'd like to share with you the lessons that we learned over the past 7 months and continue to learn, and we should have enough time for question and answers. Many of you probably have seen this classic picture of a nurse crossing the rooftops of New York, rooftops in New York City. If not, I'd like to start with a tribute to Lillian Wald. She was a public health nurse who 127 years ago started the first public health nursing called the Visiting Nurse Service of New York. It is one of the oldest not-for-profit home health care agencies in the country. Since 1893, BNS-NY has been there for New Yorkers in times of critical need. And today, BNS-NY staff members are making a difference in caring for both COVID-19 and non-COVID-19 patients. Today, in any given day, we care for about over 70,000 lives in the greater New York metropolitan area through our home care, our health plan, our newly formed licensed private pay, care management organization, and the BNS-NY Hospice. Our BNS-NY Hospice is the 7th largest hospice in the United States and the largest hospice in New York. We care for about 1,500 patients on a daily basis. Next slide. And I would like to start by sharing with you that at the corporate organizational level, we have a structure in place to respond to any emergency, as in this case, COVID-19 crisis, from planning to activation of all the departments to make sure that we continue to operationalize and deliver our services to the community, and at the same time, keeping our patients, their families, and our staff supported and safe. So just a quick snapshot or understanding of what's going on in Hawaii. It looks like just from August 10th to as of August 16th, there has been a big spike from 3,638 cases up to 5,042 reported on August 16th. This is data reported in your Department of Health. The Hawaii Island have seen a lot of increase in the cases over the last 2 weeks, and most of these recent cases are not travel related, which means that the virus is being transmitted within the community. I'm having an echo, maybe, okay, good. So just for the cases here in Hawaii, it looks like it's relatively low compared to the rest of the United States, but it is rising. Hawaii now are seeing more cases in the first 10 days of August, and then all the cases reported back in July and June combined. So I spoke to Dr. Wen as well and tried to understand your hospice. It looks like there are 5 hospice agencies in the entire state. You can correct me, Dr. Wen, if I'm wrong, but just a couple of hospitals on each island and about 40 nursing facilities in the state, but most elder care occurs in family care homes, foster homes, and in families where home health agencies and hospices must go to. nursing homes have been reluctant to take back the COVID positive patients from the hospitals, preparing them to stay at the pandemic in New York.
Rachel, we lost you here. Lost audio.
Hello?
Hi, yes, you're back.
At the beginning of our COVID-19, these are initial challenges, and it continues to remain challenges to date with the growing cases. Just like in your situation now, we have seen community transmission, lack of PPE. When the first case was reported in New York back on March 1st, there was already global shortage of the PPE. So that was one of our fears as well. And since it was community transmitted, we were looking at our staff. So we did have some staff that were furloughed because of some uh, symptoms that might be presumptive of COVID-19. And at the beginning of the pandemic, since it hit New York City, we became rapidly the epicenter in the United States. We became the hotspot. Not knowing what this virus was like or what it was going to do, we had to adjust our policies and procedure with the oversight of the Department of Health. We followed CDC as well as looked very closely and followed the guidance of the WHO. Health disparities, and did we lose audio again?
We did, but now we hear you.
Oh boy, okay.
So
I'm trying not to move, okay? So as you're aware, New York City is a very diverse state, and we do have a lot of health disparities, but we treat with all our patients with respect. So we have our unique sets of
Dr. Dignam, I wonder if you can call in on a phone line because your audio is very unstable.
I'll text her.
Can you hear me better?
Echo.
Oh. Hello? Could you hear me better?
Yes, this is better.
Okay, much better. Okay.
Okay.
I apologize. Okay, at the height of our the pandemic in New York in March, mid-March, and then in April, as we were trying to help the hospitals unload the patients back to the community, we did have challenges with our shortage of our PPE. At the same time, the nursing homes who were caring for their COVID-19 patients, they were actually not letting our staff go in to care for our patients. So there was initial refusal of the skilled nursing facilities to allow the the hospice staff, and even our home health aides to visit the patients. And the patients in the skilled facilities. There was a requirement at the beginning of when we care for patients in nursing home, there was a requirement of having our staff and also the nursing home staff test the staff for the COVID-19, making visits to the patients. Okay. And as you could see, as the death surged in New York, there was so much death. And the first death that was documented in New York was on March 13th. And with the volume of deaths occurring in the community, the morgues and the funeral homes were overwhelmed. And it was all featured in the news. And we did try to help the funeral home directors as well, working closely with the Department of Health by completing the death certificates within 24 hours. So how did we respond to the COVID-19? So as we are caring for our patients, we really continued to offer the 4 levels of care in hospice, such as routine home care, continuous care, general inpatient, and the inpatient respite care. In order to provide this care, these are the core values that guided our response to the COVID-19 pandemic. Empathy, integrity, and agility. In order to have these core values, these are the guiding principles when we put our response together. First, we want to keep our patients, their families, and our staff safe when we provide this level of care. And we continue to address New York's pressing public health need by supporting to decompress the hospitals because of so many COVID-19 patients at that time. At the same time, we also mitigate the impact to the organization wherever possible. There was a rising cost in trying to procure our PPE and training of our staff. So when we put our response together, this is the planning framework that I just want to use. They are not linear. When we were responding, they were all interrelated. So I just want to briefly go over with you how we shift our office staff to remote work, how we continued our communications with our employees, we work closely with a human resource department for developing policies and procedure to continue to support our employees. We continued also to do our supplies and PPE procurement and manage that. At the same time, while we are monitoring our care delivery, we are also looking at the volume, how it impacted, and kept financial tracking for our costs. And I think the most important one I want to share with you is the number 6, our clinical response and service delivery. At the same time, looking at the CMS regulatory considerations and continue to advocate for our patient care delivery. So the first thing we did is to, at the height of the pandemic, beginning of the pandemic on March 13th, when there was a global shortage of the PPE, we protected our staff as well as the patients and family. But first, we shifted all our office staff to remote work. And since we didn't have enough PPE, we made sure that we still have a lot of touch points with our patients. That's why the virtual visits were created whenever possible. And we made sure that there was an ongoing communication to support our field staff. So we were not just caring for our office staff, but most important was our frontline clinicians and healthcare professionals. So there was an ongoing communication from top all the way down. So for our identified leaders of VNSNY Chief Executive Officer, she was sending daily 30-second inspiring messages. She was also doing weekly status updates and question and answer sessions. And we have our hospice senior vice president also as our leader, was giving weekly status updates to our hospice organization. At the same time, there were weekly support groups were put together to offer support to our staff, and this was conducted by our social worker and bereavement staff. To continue with our communication, there were different clinical groups that were put together. So we look at our clinical operations. We have an interagency meetings every morning, and we also have our daily hospice operations, and including our vice presidents, our directors, our leadership, to make sure that if we identified any gaps in our operation, we actually have to address it right away. So not just our management were continuing to have communication, but at the same time we made sure that our field staff, who are the frontline staff, were engaged, and they too were meeting with us to get the leadership, the management were putting and getting their input regarding the experience when they're doing in-person visits or virtual visits. Any concerns that our field staff have were all given back to the management. So they actually helped develop criteria when to do in-home visits versus virtual visits by discipline. So in order to keep the patients and community safe, we have all of this in place. We have our education that we're constant to update our staff, as we collaborated with the New York Health Departments, both locally and statewide, and also looking at updating our procedures and protocols, guidelines to reflect the most current medical information, and the communication stayed intact as well. We have our HR policies to continue looking at how we could support our employees. And all our trainings were moved to remote. So starting I believe early in March, all our orientation, we use different platforms of virtual education and training. And in July, we moved our orientation for our newly hired staff to the Zoom. Our nursing skills lab that were in-person training from April to June, we moved it. From April to June, they were all done virtually. Then in July, we're now back to hands-on training and competency assessments. And our hospice education department also continued its monthly adult LNEC training to a remote platform. So for development of our HR, the HR actually developed along with our hospice management team, policies and procedures, including our supplies and how we manage our PPE during the height, early on the pandemic, and also at the height of the pandemic. So we constantly change our procedures related to COVID-19 with the help of our legal and compliance department. And with our PPE, with a shortage, we also did a lot of just-in-time training. So the PPE protocols, which Anthony Dawson was presented to you in this series about a month and a half ago. So he shared with you how we develop our PPE protocols. They're all based on the exposure risk and follow the CDC and New York Department of Health guidelines. There was a lot of staff education for changes in our COVID-19 screen. So we developed screening for our patients and also the procedures for donning and doffing our PPE. We created different videos for our staff, and also there were live training and competency evaluation was done during PPE pickup. These are all done in just-in-time training of our PPE. So this is just an example of different videos that were created to train our staff for our donning and doffing of our PPE. And as you can see in this slide, it comes in different languages. So you can find this too. This is publicly available to you if you go on our website, vnsny.org. So with the PPE shortages, we have changed our visits in March and April to virtual visits because of the insufficient PPE, especially the N95 respirators. And that time, there was a global shortage of the PPE. Then we work closely, our organizational leaders work closely with the New York Department of Health to include VNSNY in the PPE supply chain distribution lists. We also acquired our PPE via donations in addition to purchasing the PPE. We used our volunteers and administrative staff to develop and distribute COVID-19 kits for our home care and hospice clinicians. And again, we have this competency evaluation was done during the PPE pickup. So this is just a quick review of the PPE protocols that have been revised over time. I think when Anthony Dawson presented to you 2 months ago, we had 4 protocols at that time, but now it's been cut down to protocol A, B, and C because we continue to care for patients that has previously have COVID-19 and now they're negative screen. But in protocol Cs, you can see there are household members that could still be positive as they come and go in New York to care for their loved one. So we did continue to have a surge of patients referred to us because there was so much sickness due to the COVID virus back in March, April, May, and started to see the flattening of the curve in June, latter part of June, and then July. But clearly there was a surge of admission to hospice. As you can see, we had 17% increase compared from July of 2019 to July of 2020. So for our clinical response and service delivery, our goal is really to protect our BNSNY workforce as well as keeping our patients safe because of the community transmission, and our hospice patients are homebound. So we made sure that our staff are also screened. We have our daily health screen for their temperature and any symptoms that might be presumptive of COVID-19. They were not allowed to see patients. We minimize our number of in-person visits, and we focus on short-term and essential acute care and increase the use of virtual, such as video and telephonic care whenever possible, to deliver our service to our patients. So early on in latter part of January, with the first case of COVID-19 reported in the United States, we started to have meetings with our infection prevention and control committee to start doing the putting together a pre-screening tool for our patients. So all of these pre-visit screens to identify COVID-19 risk by symptoms or by testing. You could see that our pre-visit screens have been revised since mid-March all the way to just last week. We have this updated as well. So for those, when we have PPE, most of our staff were able to do home visits with the availability of the PPE. But at the height of our COVID-19 pandemic crisis in New York, most of our visits back in March, April, and May were mostly by virtual visits. We shifted all our work to remote and all our IDG meetings. So our hospice IDG meetings that we conduct every week were all done remotely. So we have used all the different video apps, as you can see in this slide, such as WebEx, Teams, and Zoom, and our interdisciplinary team meetings were done via Skype. So another challenge that we have, because as you all know that when we provide hospice care, it's really hands-on, but because of the virtual visits, we have to create new visit codes, new ways of providing care. So there was a lot of our EMR enhancements being tested and then put into production. We have to educate our staff how to use all our EMR enhancements so we can actually continue to provide care for our patients. So telehealth became a very important part of our care delivery. So we have developed telehealth pathways that are very hospice specific, and that they were all incorporated into our EMR. So there's a lot of education going on. So at that time, our IDG hospice team never skipped a beat when caring for our patients. Our IDG members continued to play a critical role in service delivery to our patients. The hospice physicians, I work with 18 hospice physicians. They played a key role in continuing e-prescribing medications. And at this height of the pandemic, most of the primary care physicians were deployed to help care for the COVID-19 in the city. Therefore, our physicians were available to complete the death certificates. We also used and we collaborated with community paramedicine, so we can activate them to support our patients whenever symptom management is critical, because most of our patients, they were very fearful of going to the hospital, going to the emergency room. They were also fearful of us seeing them at home. So there was a lot of refusal to do in-home visits. The community paramedicine, they had their PPEs, so they're able to support us during the pandemic. when they were activated to see our hospice patients. The community paramedicine were trained to care for our hospice patient with the use of symptom management to make our patients comfortable in times of needs. We also have our social work became online to support the VNS-NY enterprise. We had critical staffing shortages at the epicenter. Therefore, because some of our staff were furloughed because of either they had symptoms that might be consistent with COVID-19. Some of them were tested as well to be positive. So we had to utilize our triage skills, such as our after-hour staff, to continue to assist our patients. As I mentioned, there was increased deaths in New York during COVID-19 surge when the New York morgues and funeral homes were overwhelmed. So our team physicians really stepped up. That time we worked closely with funeral homes, Department of Health, the Office of the Coroner Medical Examiner. We worked closely with the community attending physicians whose offices were closed so they can help out in the hospitals. They volunteered to care for the New Yorkers at the height of the pandemic. So our physicians were completing the death certificates for the community attending physicians who were still serving as attending physicians for our hospice patients. So during this time with their continuous care, at the beginning, we had a significant drop in the utilization of continuous care. For many reasons, there was either lack of PPE, there was fear of the patients and their families for any of our staff to go in and care for their patients at home. So we became creative and replaced our 12-hour shifts to 2 hours in-person visits, and then provided telehealth visits in between these in-person visits. So we reduced the prolonged exposure of our staff in caring for the COVID-19 cases or presumptive cases. So our volunteer services at that time ceased in all in-person volunteer services in mid-March. So to keep our volunteers in hospice engaged, we actually had video meetings with them. They were having events to keep them engaged, and they helped out also as volunteers in our trying to procure some PPE, such as donations, and they were making cloth masks for our patients and families. So we recently held a virtual memorial service for our VNS-NY staff that died, and to support the family and friends of staff that died. So this is part of our bereavement service that we offer to the VNS-NY organization. So at this, for our last, what I want to highlight is our regulatory considerations and advocacy priorities. So during this time, when we change our in-person visit to mostly telehealth visits, we want to make sure that we have the CMS guidelines as well. So we continue to follow the recommendation. We develop processes to obtain the signing of the election of benefits and other consents. And you could see in this bulleted slide, the way we became creative in having our field staff, our admission nurses, to continue to see the patients in person when they were visiting the patients. And we cover our tablets with a Ziploc bag, continued our procedures to prevent contamination of the tablets. So there was a lot of education that went on. So our admission nurses were still supported and to keep them safe. We used DocuSign and video to witness and obtain signed consent when our staff are not doing an in-person visit to obtain the signing of the election benefit for hospice. We use a lot of email, scanning, and video to witness and obtain signed consents. And we also have paper consents. So these are the different strategies we have put in place so we can have signed consents when patients are referred and enrolled to hospice. So the next part of our presentation is really to highlight how we work closely with our community physicians. So I'd like to invite Dr. Elyayev. And Dr. Elyayev, you can actually introduce yourself. And he is one of our who has a large home visiting practice in New York, and who has been a champion in end-of-life care. So we have worked with Dr. Elyayev in the past and also at present. So Dr. Eliayev?
Hi, everybody.
Yes. Try to introduce yourself, and I could ask you all these questions.
Of course. It's really an honor and a pleasure to be with you guys virtually. I have to say, I wish we were in person because then we could be in Hawaii, and who doesn't want to be in Hawaii? So
I agree.
It's really a pleasure to be here today. I'm a physician. I've been doing house calls for the past 10 years. We have a very large team of dedicated nurse practitioners, nurses who deliver the house calls, physicians, and I'm excited to share the story of how we underwent the COVID pandemic, and we thankfully beat it here in New York at the peak of its height. Dr. Dignam, the floor is all yours.
Yes, Dr. Eliayev, I would like to know if you could share with us what challenges did you face as a primary care provider during the COVID-19 pandemic in New York?
Definitely. I'd like to say that the challenges that we faced, I kind of have a top 5. The number one challenge was the volume of phone calls. They increased exponentially, right? So you have to have enough staff, enough team members to handle the volume of those phone calls. Number 2 was the complexity of the phone calls and the medical reasons for the phone calls increased by 10x as well. I want you guys to imagine every 4th or 5th phone call being, please help, my mother cannot breathe. Or please help, my father is burning up and we've given him all the Tylenol we've had and it's still not helping. And I read that NSAIDs you can't give. I saw that on Google somewhere. What should we do? The third challenge was many of the community medical offices, they were closed. They were closed for multiple reasons. Physicians themselves were scared of contracting the virus and didn't have enough PPE to protect themselves or the staff. And so you have community medical offices which are closed. Therefore, now those doctors that are open, as we were, to help people in this time, you get an influx of new patients, but you don't really know if you have the resources and the infrastructure to handle that volume. So that's number 3. Number 4, there were home care agency staffing issues. So imagine a picture, very common. You have a 90-year-old male who has a PEG tube living alone with a 24-hour home health aide, right? He's dependent on that home health aide for the PEG feeds, whether continuous or bolus. And the home health aide gets sick. And there's no replacements because there's a shortage. And the family is quarantined. Who is going to provide that care and that access to care in that home attendant's absence? That's number 4. And the 5th challenge was really uncertainty. It was uncertainty in treatment protocols. Hey, doc, I saw on Facebook somebody posted that hydroxychloroquine works. Should we go for it? I heard that if you do pepper and lemon spray and you breathe it in 7 times, is it gonna? We didn't know. We still don't know a lot. Access to testing, getting folks tested, getting the right testing equipment to them. A lot of difficulties there. Having our staff be properly protected. And really the capacity of funeral homes, the uncertainty of funeral homes being overwhelmed. I remember one day I had to sign off on 4 death certificates in one day. That was one of the lowest points in my young career, to be honest with you. So those are the challenges.
Thank you, Dr. Eliayev. And also, if you could also describe as a solo practitioner, how did you manage those patients? And with your practice being homebound, I know you have a very good number of patients that are chronically ill and suddenly have this surge of symptoms that might be exacerbating their chronic illnesses. And how did you manage them? Especially they had so much fear of going to an emergency room and now in dire need of medical resources. How did you manage them?
That's a great question. Number 1, so there are kind of 3 pillars of what my team and I did. And it's really the team. It was a collective effort. Can't underline that enough. Number 1, we leveraged the power of telemedicine to increase really on-demand access to care, where as soon as March 17th hit, and there was that that issuance by CMS that telemedicine is covered and you can go forward with it, we went very, very aggressive on telemedicine. Instead of sending someone and parking and PPEs, we were able to listen to people, see people, and help them via telemedicine. That's number one. Number two, the second pillar was we utilize community resources. What do I mean by community resources? Number one, home x-rays, pulse oximeters delivered to patients' homes, wound care at home so that patients don't have to go to treatment centers, durable medical equipment. I'll give you a story where we had a patient who didn't want to go to the hospital. We gave him a pulse oximeter. They were desaturating. And thankfully, a new regulation comes out that anybody who is positive for COVID can get oxygen. You don't have to jump through the hula hoops. You can get oxygen through Medicare. That was a lifesaver in and of itself. IV antibiotics. Dr. Dignam, you and I talk very often about cases as well. And there was one case that the patient was on hospice, had cellulitis, resistant to oral antibiotics. We tried and we failed with oral antibiotics, needed IV antibiotics. So normally, what is a doctor going to do? Mrs. Smith, I'm sorry, you have to go to the hospital. We were able to leverage hospice and get IV antibiotics to that hospice patient so that they could age in place and be in place from a hospice perspective. And speaking of hospice, you know, I know in Hawaii, you guys have a lot of volcanoes. And so the way I look at sometimes the last few days or weeks of life is you have all these organs in our body. And as we are transitioning, each of these organs is a volcano that's erupting. And myself as a PCP, I don't have enough resources to take care of every volcanic explosion because the kidneys are failing, the liver is failing, and the patients are calling me, family members are calling me, and I'm a PCP. I don't have the resources for a 24/7 operation. That's where hospice really came in and helped us. And the last pillar, I'll say, which is very, very important, I'll explain it with a story. I was a second-year resident, and I remember there was a man in his 80s. He was brought in, intubated, and I did the admission in the ICU. And as time went on, 5, 6, 7, 8 days, the man developed decubitus ulcers. And then he developed anasarca, as Dr. Nguyen and many of the other doctors on the line know, and the nurses on the line, swelling of the entire body from laying in the unit and intubated. And then I'm looking at it, and I, a second-year resident, I'm having a conversation with the family, and I say, wow, this is unfortunate. And they say, Dr. Ilyaev, you know what's more unfortunate? Dad never wanted this. Dad never wanted to lay in the hospital bed intubated. So I said, but how? Now me being naive, second year, I don't know any of these things. I'm like, so how did that happen? And the daughter was like, well, we didn't know our options. We never had a conversation. We never knew what the options were as far as goals of care, as far as advanced care planning. And so, from that moment on, I thought, man, what if my mom or my dad end up in that situation and they never wanted to be in that situation? So I implemented in my practice that we have to have advanced care planning conversations early on, whether it's a 30-year-old patient or a 90-year-old patient, especially in the time of COVID. And there's, I'll finish with this. There's one thing, kind of like a motto in my practice with our team, is that to avoid difficult situations, it's important to have those difficult conversations early on. And if we as physicians make it standard operating procedure that with each patient, especially in COVID, we have those difficult conversations, folks may not need to be intubated who don't want to be intubated in the end of their life. And that's those are the top 3 ways that we really help our grandmothers and grandfathers in the field.
Thank you, Dr. Alia, for sharing that. And it is very important to highlight the advanced care planning, especially during the pandemic crisis. But I think if you would be able to share any patient experience that was a success during the pandemic and how hospice have helped you.
Yes, I'll mention real quickly. There was a case where I'm sitting right here actually, and my staff picks up the phone, and there's someone calling on the other line, and they're saying, "Please, you got," and I could hear it, right? "You got to help my mom. You got to help my mom." So my office staff says, "We're sorry, man. We're closed for the day. We're not, but they call back again. "Please call us." So I said, "You know what? Let me take the phone. Let me figure out what's going on." I take the phone. "What's going on, guys?" "Well, EMS is here." And this is an immigrant family from Russia who came here about 10 years ago, but they don't know the system. They don't know things well. The EMS came and they said, because there's no healthcare proxy, nothing, the nurse said that my mom has a wound and she has to go to the hospital, they said, but mom wants to die at home. She doesn't want to go to the hospital. So I speak to the EMS representative. I say, "Listen, they don't want to go." He said, "I can't do anything. These are the rules of New York. There's no healthcare proxy. There's no living will. They got to go." I said, "All right, Lynn, do me a favor. Can I talk to the family?" I said, "What are the goals of care?" Over the phone. This is not my patient at this point. "What are the goals of care?" Have a goals of care conversation. They said, "At all costs, do what you have to do, but help mom at home. We understand the risks. Do it at home." I say, "Connect me to your medical command center in the hospital." They commend me to the command center. There's a doctor who picks up. I say, "Listen, I got this. I'll take responsibility." Why? Because I know I have resources at home. The nurse said that there's an issue with a wound. We can do the best we can with wound care at home. I could offer hospice at home. The doctor said, "You know what, Eric, that makes sense. What's your name? What's your last name? Discuss with Dr. Eric Eliayev. He will take over the case." Okay, great. I call hospice. Hospice comes in with their wound care team. Hospice is able to deliver, and this is during COVID, a hospital bed with an air mattress, because there were really, really significant DQs, as well as literally the next day. And to tell you the truth, to end on a happy note, the patient survived. The patient is still palliative, still hospice, but she made through it. She didn't have to go to the hospital. And she's at home, aging in place where she always wanted to be.
Thank you very much for sharing, Dr. Eliayev, to see how we collaborate as a family, as a primary care physician, involving the hospital, the ER, and also the hospice staff. Thank you so much. And thank you. And I would like to end this hour by really showing our DNSNY hospice what we have learned over the past 7 months. It's been a long 7 months, and I know we are in for the next fall season coming. So I would advise that in order, as we delivered our core values of empathy, integrity, and agility, we have a structured way of our emergency response planning. We have appointed leaders that help make sure that all the communication and keeping our patients, our services, and our staff also safe. We have safety in our workforce. We have honest, open, and frequent communications. We keep our staff with high morale. We work closely with our community physicians, hospitals, and nursing homes. We have daily adjustments of our policies and procedures. And now we are stockpiling for the 90 days coming, and also look for the silver linings. And so at the end of the day, we can endure much more, and then we think we can. So please, if you have any questions and answers, I am available, and our team is also available to answer questions.
Okay, thank you very much. So I think we have a question here already. It says, was there a source in New York for backup of emergency caregivers?
So, so the caregivers, I think, are you talking about professional caregivers or home care?
Hey, this is Dr. Lev. I was the one who wrote that. So one of the concerns that we have is, that if our hospice patients' families themselves get sick and they are acting as caregivers, or if our hospice patients who are in care homes have their caregivers get sick, and now suddenly our hospice patients who are at home or in a care home don't have a caregiver, we would be faced with having to send them to the hospital. We don't really have a source for an emergency caregiver, either a medical professional or not. And I was wondering how y'all dealt with that situation in New York.
So from our perspective in New York, as many of you may have heard, in those situations, patients were sent to the nursing home. And we know how that ended up, right? A lot of folks got reinfected and, a lot of folks got infected in the nursing home from the patients who were sent to the nursing home. I personally had patients who were sent there because that was kind of like the protocol of the social workers and the home care. The key for you guys early on in this is to identify, okay, how can we solve this problem? Can we isolate a location within a certain entity that those folks can go, and they will definitely be separate from the other population in a separate building, right? That would be a solution to start working on right now, because, you know, it's better to learn from the mistakes of others than to make mistakes yourself.
Yeah, so Dr. Takeshi Uemura, did you want to speak up? You had a comment about this to sort of follow up on that question, right?
Sorry. For my question? Mm-hmm. Sorry, I missed it.
Yeah, so anyway, so Dr. Yeah.
Sorry, go ahead.
Oh, no, I was going to say that, you know, he was going to ask if you have COVID hospice patients who develop severe symptoms and dyspnea enough to require transfer to an inpatient palliative care units or other facilities for symptom management. And did you have a facility that was capable to handle those COVID patients, those hospice COVID patients for symptom management?
So that is part of our, in our hospice service. So we do have our GIP contracts. So if there was a bed capacity, we're able to move some of our patients to an inpatient setting to provide care. But I know in the middle of the pandemic, the height of the pandemic in March and April, the hospital beds, they were so overwhelmed that we cannot even move the patients in that setting. So what we have done is to provide care at home. And we did continuous care later on when we have the PPE. At the same time, we were also able to provide more touch points with the patients with the use of the virtual visits and telephonic support. And that was not of a problem when there were caregivers at home. So the difficult time if there's no caregivers for our live alone. So I would suggest also that which we have done is to really plan ahead of time for our live alones and for patients that are declining at home, such as the ability to move them to the nursing homes.
Yeah, one of the things that we're thinking about in Hawaii in terms of planning ahead is having something like a COVID unit in a nursing home to be able to absorb people in the home, care homes, whose caregivers have gotten sick or things like that, that situation. And I guess we should be including people on hospice as well.
Mm-hmm.
That's correct.
So one of the things that happened, and certainly a lesson learned, was how the skilled nursing facilities now, let's put it this way, have learned to cohort patients and set up units, sort of pre-testing, and then move them around in various units based on negative and positive results. I think we did learn the lesson that they weren't prepared. And we, at that time in New York, again, all over, that the transmission and how it was transmitted and what the expectations were for PPE for their staff as well, were all limited. And it was a learning situation. One thing remarkable that we did experience is that patients and their families were so reluctant to go to the EDs because that certainly was the pandemic and the news and the media, what was going on in the EDs and in the hospitals. So we found that patients were far more compliant. And then we, as Dr. Dignam was saying, we stepped up our community paramedicine, our telehealth, the other things that we do to keep the patient comfortable at home. So we saw a marked reduction of what we would typically see of at any given time pre-COVID wanting to go back to the hospital. So much more compliance in that area.
So
yeah,
to follow,
and also, Dr. Wen, just to mention that during the height of the pandemic, when a lot of businesses and offices were closed, there were more caregivers available at home to really care for their loved ones. We also really work closely with them.
Okay, great. There's a follow-up issue about maybe if you could explain the community paramedicine service and if you contracted with them to help with their hospice patients. How did that work?
So our organization have put together a program. We have specialty programs to increase our services at home. So we have our cardiac hospice program, we have our COPD hospice program, and another program that we have partnered with Mount Sinai is their community paramedicine. So we have a contract with them, and we actually help train both of our organizations. So the community paramedics, Dr. Munjal, the ER doctor, come to our organization to train our staff what they would do and what are the services that they offer. At the same time, I was also involved in creating the curriculum and train the paramedics how to take care of the patient, hospice patients at home. They were very familiar with our comfort kits. So we developed protocol with them when we activate the community paramedics to when our patients start to have uncontrolled symptoms at home and they refuse to go to the ER, refuse to be moved to an inpatient setting, we activate them and they are there to give the symptom management for the patients. So they are all trained of what are the most common symptoms that we encounter at end of life, what are the most common medications to control the symptoms.
Thanks. There's a question here about regulation on oxygen being easier to get. I'm not sure we have that same experience here. Maybe you could talk about.
Sure. Jeanette, I think you asked the question. If you can shoot me an email, I will send you the document that we received here in New York, but it was a federal, it was all Medicare from what I understood, and I'll forward you that information.
I have a question as well. I'm one of the residents here at UH. I'm rotating currently with the geriatrics. One of the issues that we've primarily run into is, suppose from my primary outpatient practice, referring people to hospice and getting them into care homes for people who qualify for, assisted living care facility or SNF level of care. How did you guys go about that? Because that's something that we are having an issue with. In terms of people going from hospital to facilities is not an issue. But if someone is at home and they kind of qualify for SNF level of care, it's difficult getting them from a home into a facility. Do you have any comments on that?
Well, I
Linda,
think,
yeah, go ahead.
Yeah, so I think, New York and Hawaii, I'm not sure about the regulations. One of the requirements for skilled nursing is a screening, we call it a PRI. And I think it was difficult for our staff to actually do that screening to allow them to be admitted to the skilled nursing facilities. And the other aspect to both the nursing homes and the assisted living, adding to the reluctance of people wanting to go, is that they did not allow any visitors. So once they would go into a nursing home, and even today, months later, it's very restrictive. And in fact, we are under an executive order that requires all of the staff in each nursing home to be tested once a week, as well as our staff going into it. It's been very difficult, and I don't know if, the lessons learned of cohorting and setting up infection control for admissions and maintaining patients in safe areas within the nursing homes has made a lot of difference. But during the time, we had a very difficult time getting anyone to go to a skilled nursing facility. We had the lowest level of readmission. Like, we would have, out of 1,400 patients in any given week, we may have typically 20, 25 that might discharge for any reason, not just going back to the hospital, but it really dropped to almost zero. So that was our experience. I think that, again, the assisted living, the testing, the shifting of requirements, it's still every day is a challenge for us.
Right, and that continues to be a challenge for our home hospice patients that will need nursing home care or assisted living care. They need to be documented to be COVID-19 negative. So our hospice agency is now trying to have a contract with some organizations who would be able to do in-home testing for our home care patients when we are now planning to move them to a nursing home. So testing is continues to be a challenge in New York.
Right. I think that was probably one of our biggest challenges, was that testing is a big issue. Like, I think we have enough tests available now here, but again, people being tested at home before going into the facility was the issue. Thank you for bringing that up.
Yes, thank you. Aida, I think you're muted. Okay.
Yeah, it is 3 o'clock, and I know that we probably want to just keep talking because there's just so much information and so much experience we'd love to share. But I'm gonna, let people go if they need to go. I just noticed that here Naomi Morita mentioned something about paramedics with EMT doing home health care. How essential do you think that was for dealing with the surge?
I think they have been very, very important in caring for our hospice patients at home. Even our home care patients, they were available. So knowing what your community paramedics can do in your community is going to be very helpful. So their availability, and they have the PPE, because in the height of the pandemic, the hospitals were the first one who got in the distribution lists. We have to ask and meet with their leadership and our leadership, just with the Department of Health, to get us on their, supply chain. So we were lucky to have a contract with our community paramedics.
Yeah, it's good to have that in advance. I guess we still have a ways to go in terms of getting something up and running.
Yes, and
like
if
that
you,
to be ready.
and if you would be able, and if you would like, we could share and help you how to put it together. So Linda Megan was also the key person to really help with putting our community paramedicine program as well.
Okay, great. Thank you. So so I think unfortunately we do have to end, but thanks so much for sharing with us today. And I just want to encourage everybody to get on, there's a link in the chat box, or just go to the website and do the evaluation. You can get all your CMEs. And please join us on September 2nd, where we're going to talk about updates and PPE testing and contact tracing here in Hawaii, because a lot of things have changed since the last time we talked about this. Yes. So thank you so much, and take care, everybody. Stay safe.
Thank you. Bye.
Bye, everybody. Next time in person.
Oh, yes. Wait,
come to Hawaii.
Yes.
Wait,
yes,
I think I have to come and really help you.
Yes.
Directly.
Yes, please invite us. We'll be there. Thank you.
Be well, everybody.
All right, take
Bye.
care.
Bye.